We were dealing with an unknown disease, a global pandemic. As you rightly said, it was evolving very quickly. We had new cases appearing almost on a daily basis, and having to support people individually while those of us working in public health were thinking about what were the prevention tools, what were the policies, how do we mobilize the nation around this emerging epidemic.
The importance of doing this together, the importance of sharing what we all knew with each other and understanding that knowledge across boundaries, I think was incredibly important.
London has been, over the last 8 years, a testing ground, but we've brought the best minds around the table from so many different sectors to think differently about the problem and to act differently and to try different things.
I'm most proud of the partnership where we now really have deep understanding of each other in a way that has enabled things, and it is held together. That's what I'm most proud of.
Welcome to the First Track City's Getting to Zero podcast. This month, we sit down with the co-chairs of Fast Track Cities London, Professor Kevin Fenton and Professor Jane Anderson. They take us through the very beginning of the partnership, through the incredible collaborative work achieved so far, and discuss the challenges overcome along the way. Most importantly, they look at what's on the horizon for us to reach our 2030 goals. 0 HIV-related deaths, 0 HIV transmissions, and 0 HIV-related stigma in London.
Jane, hi. I'm so glad we're here today, and I'm really looking forward to this conversation with you. We've been working together as friends and colleagues for more than 3 decades, if not 4.
A long time.
A long time. But I don't think we've ever had a chance to sit together just to share stories and our reflections. So
not in this way, and it's really, really pleasurable to be able to just reflect back on how did we get to here, and how did our lives and our work bring us to be sitting on these sofas today.
That's right. That's right. Tell me about your story, because you're a clinician, you've been in the field for a while. What was your journey to Fast Track Cities?
First and foremost, I see myself as a clinician. And working in hospitals in those very early days of the AIDS pandemic was very, very formative and very powerful. And the experience of being a young, newly qualified doctor on the AIDS ward at St Mary's in 1984 stuck with me. And I came to medicine a bit later in life. I'd already done a PhD and another degree. And I think I saw things there that I began to realize we had to change at a really fundamental level. So those very first days as a doctor, I think, are what set me on the track to being here with you today. I became a consultant in 1990, still before the drugs arrived, with the task of setting up a new HIV/AIDS unit at St Bartholomew's Hospital, which was a huge task. And at that time, interestingly, the policy agenda was expanding consultant numbers, expanding centres, and Barts was able to say they wanted to establish a new centre. So myself, and I don't know if you remember him, but Don Jeffries, one of the most wonderful virologists. Don was appointed to the chair at Barts at the same time as I was appointed as the consultant position. And between us, we had no ward, we had no beds, we had no dedicated staff. We worked it out and started to make things develop at that point. We were really fortunate in that we were joined by Tony Pinching, again, Professor of Immunology. We managed to create a chair of immunology at Barts. Tony came across, and again, thinking about the policy aspects, at that time, Tony brought over about 250 patients from St Mary's. So thinking about service delivery in London and the way people moved at that point was also really important, but it gave us critical mass to actually set things up and to build a ward and to build an outpatient centre and to build some mental health facilities. And of course, always at that time, Barts was attached to Homerton in Hackney. And I saw the way that HIV was affecting different populations in different ways. And at that point, I began to really see that medicine alone wasn't going to cut it.
Yeah.
It's a prescription pad and a stethoscope can only take you so far.
So
This
far.
was about migration, housing, policy in every possible area.
And I think that's how and why our paths have crossed so many times over the past few decades. So you know me, right?
Yeah,
So
well, tell
I
us about
started
you.
off as a dyed-in-the-wool public health person.
Yeah.
And the reason I chose public health, I think, was just before I finished my A levels, the first cases of an unknown disease affecting gay and bisexual men. You remember in 1981
Yes.
in New York and San Francisco were reported. And I, to this day, remember those vivid images on television of these men who were dying from this unknown disease, and the fear and the stigma and the hate and the discrimination because they were gay, because it was an unknown disease, and there was fear. And I remember even at a young age thinking, if I ever do medicine, I want to be a part, whatever I do in my life, I want to be a part of helping to bring this unknown disease to an end. I went into medical school, and very quickly I realized that I didn't want to be a cardiologist or a neurosurgeon. I wanted to do public health because I learned really quickly that the way to improve the health and well-being, not just of one person at a time, but of hundreds of thousands of whole societies and communities at a time. And what you could do to truly create a legacy of health was what really resonated with me as a young medical student, as somebody coming into medicine. And I had the privilege after medical school of coming here to the United Kingdom to continue my postgraduate studies. And I think we probably first met in the early 90s when I did my clinical rotations in infectious diseases and HIV medicine, and then got my first job with Ann Johnson at UCL as a lecturer in HIV epidemiology. And these were the early 1990s, Jane, and it was very clear that not only were we trying to do research to understand prevention for HIV, but health inequalities that were emerging at that time with HIV. And clearly, gay and bisexual men were bearing the brunt of the epidemic in the 1990s. But we saw the emergence of other populations, people who were in-migrating to the UK from high prevalence countries, especially Black African communities, migrant communities, the disproportionate burden on injecting drug users, commercial sex workers. And so my early research really got me interested in defining inequalities, understanding inequalities, and doing research to develop some of the tools to engage those communities and to empower them to tackling the epidemic. So when I look back, some of those early values of my love for public health, my love for combining research and practice, the central theme of health inequalities that has been through my entire career, but the value of engaging communities to be part of the solution really began back in those early days of doing HIV research. And then, as you know, over the years, I've worked here in the United Kingdom, worked in the United States doing HIV work and other infectious diseases. And so for me, it's a real privilege now to be back here, to be working alongside you and our brilliant colleagues on Fast Track Cities to think about HIV in the 21st century and how we bring this epidemic to an end.
I think that's really powerful. And I was at UCL just before you at James Pringle House, and I think we maybe just overlapped. But of course, as a clinician in the front line, a lot of what we were doing was direct clinical work. And that bigger picture that you're talking about of public health was much harder to focus on when day to day to day to day, more and more people are coming through the door, and you are actually trying to ensure a decent clinical service with ever increasing numbers of people, most of whom died. And so it was really hard, I think, to think more strategically at that stage because the sheer volume of people that were arriving. So, and it wasn't really until after 96 when we had effective drug treatment, the concept of either living well or living. And that treatment could in fact be preventative. We didn't know that until much later on.
In the early 2000s.
And so that differential perspective of a public health population view narrowed into a day-to-day clinical practice and how to make those two things actually complement each other is something that we've done in HIV, which hasn't necessarily been the case in other areas.
I agree. And I think necessarily we, in a sense, had to be that way because we were dealing with an unknown disease, a global pandemic. As you rightly said, it was evolving very quickly. We had new cases appearing almost on a daily basis and having to support people individually while those of us working in public health were thinking about what were the messages, what were the prevention tools, what were the policies, how do we work with politicians, how do we mobilize the nation around this emerging epidemic. So I think one of the things we learned, and I definitely learned in my HIV career, was the power of working across disciplines and creating partnerships, because at the time, no one of us had the answer. And that meant we also needed to engage patients as well as key stakeholders in finding this solution, because none of us did.
No, and it was that crucial ability to share knowledge across boundaries, across all sorts of areas, which was very unusual. So the importance of doing this together, the importance of sharing what we all knew with each other and understanding that knowledge across boundaries, I think was incredibly important. And I remember at UCL, at the Middlesex Hospital, frontliners who produced a fabulous booklet called Dealing with Your Doctor, which was one of those early publications about how we could work better together. And we were really privileged to have a number of activists who made sure that the up-to-date information that they were hearing was arriving with the medical profession as well. So there was a sense of being much more able to share intelligence, information, and those hierarchies, I think, were much flatter in HIV than in many other parts of medicine, which of course was another reason why it was such a powerful place to work. And I would also reflect, going back, if I think about being a houseman in 1984 and the way that our senior colleagues dealt with what was coming down the line for them, we were very, very fortunate to be taught by people who thought outside the box. They saw a problem that was new with a community that was particularly affected and worked in imaginative ways. And we were trained by those people. And the people that didn't want to work that way didn't get involved in HIV. So we were... I certainly was taught and mentored by people who were, they were not the run-of-the-mill consultant clinicians of the day. They were people who already saw new ways of doing things, which made them very inspirational to work for.
Well, you know, I also have my clinicians and mentors who really helped to disrupt my model of medicine and what I thought about medicine. But can we have a shout out to the activists? You said this. Because I don't think we can understate or overstate enough how critically important advocates have been in every stage of the HIV response. And for me, it's been the anger, it's been the hurt, it's been the pain, it's been the grounding that the advocacy voice, the challenge that the advocacy voice has brought, that has kept me real as a clinician, as a public health expert, as a leader. And it's that reminder that we have a responsibility, a shared responsibility to leave this better for those who come behind us. But the advocacy, the relentless advocacy through the HIV epidemic has been one of the keys to our success. And I think as we thought about the Fast Track Cities program back in the mid 2010s, when you and I again started to work together again in Public Health England, there was no question that we were going to create something that had the community alongside the clinicians, public health experts, policymakers to solve a wicked problem, which is how do we accelerate our progress in London? So those early values, which began for both of us, really are things that I think we've been bringing through
Absolutely.
into the Fast Track Cities program.
No, I completely agree. And I think there's been something about, particularly about the people who I have been blessed to work with in East London. I very quickly realized that there were far more women, and particularly women from migrant communities, who were having the most complex and complicated lives, some of whom were able to advocate, but many were not able to have that advocacy role. And the needs and the unmet needs in some of those communities were so profound and made good clinical care impossible without dealing with those things. And I met women from Black African communities who taught me at that point what we needed to do and helped to shape the services that we needed to provide. I'm not sure all of them know they did that, but they were instrumental in setting up what we have now, certainly in East London. And I was in those early days looking after or helping to look after women who were pregnant, living with HIV, women who would like to become pregnant, and what does a good maternity service look like? And that took quite a lot of work, but it was the advocacy of people who were going to be using that service that shaped how we tried to make it work.
Yeah, and that's interesting because in the same way as a public health person or community participatory work and research that we did with African communities and gay men also shaped the kind of research that we did. So you remember the Maisha study.
I do.
Back in the day. That was the first study of sexual attitudes and lifestyles of African communities. That fundamentally changed how we engage communities, how we train them in research methods, how they began doing the peer outreach, began collecting data, began analyzing their own data and telling their own stories. And one of the great legacies of that early research project done in the 90s is that many of our colleagues we worked with at that time ended up continuing in advocacy, going into research, studying further, and are now a crop of leaders, advocacy leaders that we have today.
And I would just go and reflect again on that because, again, this was at Homerton particularly, so many women from Black African backgrounds arriving in the clinic. And I remember sitting with Leslie Doyle, professor of sociology from Bristol, saying, oh, there's so much, and what are we going to do? And she said, well, we need to do some research here. And she said, I know about sociology and you know about medicine. So we set up a joint project together to actually do some really robust work that could demonstrate the things that we were seeing and to give some research to that. So that first study we did, which we published in the early 2000s, actually describing in very robust detail the lives and the challenges of women of African backgrounds living with HIV in London, shaped so much after that. We were able to point to robust data because it's anecdote versus data. You don't move forward. So the importance of ensuring we could document, analyze, and put forward robust data and intelligence has been so important.
It really is. And I think that's another key to success in terms of our work in the past, but even more so in our Fast Track Cities work today. So I wonder, shall we talk about Fast Track
Yes, we
Cities
should.
and the history of
yeah,
Fast Track Cities? You know, our lives, Jane, have, we've been alongside each other. As you know, I spent a decade in the US. I came back and worked in Public Health England. And very soon after I arrived, I remember you approached me and said, Kevin, we need to ensure we have a national focus on HIV, sex and reproductive health. And I said, absolutely, let's do this. And we worked on some really interesting things. The first sexual and health strategy for gay and bisexual men, really thinking about bringing in the reproductive health component of the work into national public health agency. But most importantly, thinking about HIV prevention and the implementation steering group of the HIV strategy at that time. But we also thought that we could do better. And there was an opportunity with the Fast Track Cities program, Jane. You want to tell us about those early
I think
days?
I'd just go back a bit before that, because when the government really decided to shake up the system, and Andrew Lansley's bill was under debate, I was the chair of the British HIV Association. And once the proposals were clear about what was being suggested, it became clear to those of us working in HIV at the time that the system was going to be fragmented, and that we were going to see a disconnection between the NHS service provision and local government prevention. And that was a risk. It had potential for great benefit, but it had potential for great risk. And I, at that point, with Beaver, went to see Duncan Selby, who was the newly appointed Chief of Public Health England, really to advocate for how this new arrangement of the system, the risks it posed, unless we had some clarity about how things were going to work together, where the joins were going to be, if the budget for prevention was going to be completely dissociated from the budget for treatment, how was that going to work? So it was that very disruptive health and care bill that went through in 2013, 2012, 2013, that I think precipitated huge amounts of concern about what was going to happen next. And that was when, at PHE, we had that opportunity to say, okay, how's this going to work? And that was a real moment, I think. And it was a difficult time. It was a very difficult time, because it shook up a lot of things. And in a way, that was the impetus, because the jigsaw pieces had been thrown into the air. And how were we going to bring that back together to a meaningful system piece when everything was fragmented across the system? And at the same time, in 2014, the 90-90-90 targets were promulgated by UNAIDS. That was that bit of modeling, that if we could do that. So those two things came together with a sense that, okay, we've got to try and get the system to be looking at those 90-90-90s. But in this country, the bits of the 90-90-90s are everywhere. But we've got places, and we've got political leadership in places, and places can collect their bits of jigsaw puzzle in a different way, and we can do this together if we think about it in that way. So it was that, for me, that mixture of the Lansley reforms, a moment where there was a model for 90-90-90, how do we put that together with everybody, with every piece of this jigsaw coming together? And of course, most of us, when you're doing jigsaw puzzles, are doing sky or trees. But with this, we have the opportunity to do the picture and see where that's going to take us to prevent and to get to that 90-90-90, now 95-95-95, now beyond that, getting to zero moment.
So I think people will miss this reality that fragmentation has always been the big challenge that we have to face. Part of it is because HIV prevention, treatment and care are not the responsibility of any single provider. And if you're wanting to provide holistic treatment, prevention and care across the life course, you have to work together. But as you rightly say, in a health system where the commissioners and the providers and the community and the academics are all working in different bodies, that ability for us to bring people together and to hold people together and to have a shared mission that we're working towards becomes increasingly important. And you've heard me speak over the years about systems leadership, what we do in public health, which is around recognizing the complexity of systems that we're operating in, but using the power of convening, the power of partnership, the power of data to ensure that we can understand and have a shared understanding of the problem, holding each other to account to deliver on the things that we say we would deliver. And of course, making progress through working together has been a key part of solving some of the challenges that we had. But it sounds easier now when we say it, but my goodness, back then, we realized how heavy it was, how difficult it was, because the fragmentation that we had at the time was a challenge.
Well, it was a huge challenge because not only was the system as the commissioning and the budget in different areas and different organizations, we also had a workforce in all those organizations who were trying to work out how the new system worked for them. And I remember very clearly 2014 was the beginning, the first conversations internationally about fast track cities. And it seemed to me to be a perfect moment with all these bodies, all these, the need for partnership had never been greater. And actually, the thing that perhaps we could have done differently was at that point, people weren't in a position yet to know how to do things together because they were still trying to work out what their role was. So I remember going with great enthusiasm saying, there's this amazing thing and we could do it in London. And they went, okay. Well, can we just come back to that when we know what workforce we've got, what budget we've got, how we're going to make our organization work? So there's a moment when not only do you need partnerships, but the partners have got to be solid for themselves. And there was a lot of shifting sand, which meant that to form a partnership was difficult until the partners were able to identify their roles and responsibilities. And that was a really challenging patch.
It was, because I remember there are a number of occasions you and I went back to the then public health director for the city, our wonderful colleague Yvonne Doyle, and saying to her, Yvonne, we can do that better than what we're doing in London. There is an opportunity for us to go further. And you're right, at different points the council was, this is not the moment just yet. But then things eventually aligned. We had a mayor, we had a much more stable system with, as you say, directors of public health taking ownership and leadership of HIV. Commissioners in London began working together, thinking about London as more of its sum of its parts. We, of course, had our advocacy community wanting London to go further. And as you've mentioned, UNAIDS setting bold targets for cities and nations to accomplish. What was important for you in those early days of landing fast track cities?
The important thing for me was that we had to get everybody to put their contribution in, because without everybody's contribution, we couldn't do it. And the it at that time for me was about stopping new infections, but also ensuring that the people living with HIV were able to access the treatment, the care, the services that were needed. And that was really complex and still is really complex. What was happening in the voluntary sector, because if I go back then, by the time I left PHE, I became chair of the National AIDS Trust. And of course, that is our body, for our voluntary sector body, looking at the rights and responsibilities in the system. That moment of getting more involved in the policy and the rights part of how HIV was going to go forward meant that a whole system approach, everybody contributing, because we are blessed in this country with some of the most amazing clinical teams. We have amazing advocacy. We have fabulous voluntary sectors. We have local government. We have all the ingredients. Unless that coalesces and everybody puts their bit of fabulous ability in, it doesn't work as a whole. So for me, I was really in trying to ensure that all those things were able to do their magic in a way that was going to make the difference. And I could see when we were advocating for this that if only we could all just contribute together, but in a system where budgets were divided or people weren't necessarily able to know that there was a shared direction of travel, if you like, that became much harder. And if I think again where we were then, it was, you're right, it was when Sadiq Khan put out his manifesto where HIV was actually named as a priority for our city. Then people were able to come in behind that.
That's right.
So I think that was an absolute turning point.
I think that was a turning
Crucial.
point. I think the appointment of the mayor, Sadiq Khan, and the political leadership. We also remember in the mid-10s, 2010s, that was also a very fractious time as well, because we had HIV PrEP availability and the national debate that we went through of trying to get PrEP in the NHS. And that was running in the background as well in terms of the advocacy fight, the pushback from the NHS, and the need for us to really step up our HIV prevention response, because we could see that gay men continue to bear the brunt of the epidemic, and we had not yet begun to see the real declines that other Western industrialized countries were seeing. So we had imperatives as well, but we also had the political leadership coming in. And we worked with the mayor to say, can this be one of his initiatives? Can we now, under the mayor's ambit, begin to think about a way of bringing system partners and the community in London together to create this new opportunity for London in the Fast Track Cities programme?
The other thing we have to remember at that point, of course, is London had at that point achieved 1990.
We had.
So we were having to think, how do we make the case for going further and faster? And some of the pushback was, well, we don't need to do this because we've met that target. To which the answer is that's not enough. And going further and faster is the next thing we have to do, because we've got, even if we've got to 1990, we're not seeing the results on the ground of what that needs to be. So it's got to go further. So to take that next message of getting to zero, that next message of bringing everybody together behind zero stigma, zero new infections, best quality of life, that also seemed to me to be really, really important. And it was a challenge, because if the original message was we want to get to here and we've got there already, why do we need to go further? The PrEP discussion was so important at that time, because the PROUD study was going on, the data was coming through, and of course it was landing in a system where the responsibilities were still different and harder to work out. And just as I took over as the role of chair of the National AIDS Trust was when NAT took NHS England to judicial review in partnership with the local government association. And that was advocacy at its absolute finest. And NAT actually having, although they brought the case, it was bringing together a huge coalition and partnership of advocates, voluntary sector, community organisations to bring that judicial review, which was successful. And of course, NHS England appealed, and I'm afraid NAT won again. And we have the consequences of that. But that was community coming together with the system, with the legal system, to actually push that forward.
That's right. So I think what we've been able to just show the ways in which advocacy works, direct action through legal, through policy, through partnership. And that's why, as I said earlier on, that for me, the critical role of advocacy must always be a core theme of any story
Absolutely.
for HIV today, in the past, and in the future. So, Jane, I have such vivid memories of that period, the early days when we were thinking about fast track cities, and that work between 2016 and 2018, where I think you did a lot of the legwork to get this started. What stands out for you in terms of your memories? And can you just paint the picture between 2016 to 2018 when it was launched with Sadiq Khan?
It was a really important time, and trying to work out what needed to be done. Debbie Laycock, who took on a secondment to Sadiq Khan's office, prepared. She did a lot of the legwork at the beginning about thinking what would need to be done. I think she had a 6 months or a year secondment there, and that gave us the basis. Jose Figuera was leading public health in the NHS England, London region, absolutely instrumental, and his support with the mayor's office was absolutely critical. London councils also came in behind, but we had to try and find out how to host it. If it's going to be a partnership, where's it going to sit? Where's it going to have its support mechanism? That was really complicated, and we found people weren't keen, actually, to take the full accountability and responsibility. Luckily, Healthy London Partnership had been created as a space and a place where things that were whole system for London could be held and looked after. And I approached Gemma Gilbert to say, what do you think? And Jose Figuera was absolutely convinced this was the right home for this particular partnership. And Gemma said yes.
Wow.
And so those very early meetings were in HLP offices in Marylebone, a small group of us trying to work out what next. How do we get from this is what we want to do to a full partnership, signing up on the dotted line with a plan? And there were a lot of meetings, people coming together. But at that point, and I think this is really important, the statutory bodies were the people that were leading it. And we were very clear we needed to involve advocates. We needed to involve people living with HIV. And that took more doing because it was much harder to see where in those system leadership pieces they would fit. But actually, it was critically important. Mark Thompson was the first person who joined us to help think through where is the community? How is this going to work together? He was absolutely influential. But it took us, it took a year, 18 months. We had a big meeting together at the King's Fund. They hosted us. And we just looked and said, who needs to be in the room? Let's invite everybody to come and talk about this. And I think at that point, it was absolutely clear you were holding a big leadership role for London. And everybody said, well, we've got to go and get Kevin. Where's Kevin Fenton? And we invited you to come to that King's Fund meeting. You came, and here we are.
Yeah.
And that was 2017.
2017.
I think.
And then
maybe 2018, but it was very early days.
Yeah. And then the formal signature with the mayor, the Director of Public Health for London, system partners and the community. I believe that took place in January of 2018.
Yes, it did.
So now this year we celebrate the 8th year of the signing. We're now entering the 9th year of the program. What are your memories of the signing?
It was very powerful, and I think we should absolutely pay tribute to Yvonne Doyle there because she was leading the PHE office for London. She was advising Sadiq, and actually she facilitated a huge amount of that work. But we were clear we needed to have other cities, the mayor signed. And we said, no, London doesn't work like that. we have to have 4 signatories. And actually, with hindsight, we should have had more signatories,
Yep.
because actually the people that signed were the people with the accountability for HIV in our city. And so it was the mayor, it was PHE London at the time, of course now dissolved, NHS England London, and the London councils, because those were the 4 statutory bodies where the accountability began and ended.
Yeah.
The importance of the community and the advocacy as accountable bodies at that point was not properly recognised. And had we, I think, the opportunity to do it again, that would need to be even more signatories to show that everybody was behind it. And of course, at that point, we brought in the other people internationally who were involved, and so other partners across the world. IAPAC, who were leading some of this, came to the signatory. So we had it was in London's living room. It was when we were still in Sir Duke's office was still in that fabulous building overlooking the Thames, Tower Bridge, Big Ben, London, absolutely on fire, signing up as a city to doing this.
It was, I think, such a pivotal moment. And I don't think you and I take for granted that having the mayor front up an HIV campaign for a city of 9 million people back in the 2010s is anything that is more than we could have hoped for. And the mayor, to this day, every commemorative event, he wants to lead for HIV. His commitment is undaunted, and he continues to be a fantastic advocate for this work, and incredibly proud of what we've accomplished in London as well.
In London, the role of the mayor has been absolutely pivotal, because London is a city of 32 plus the City of London boroughs, each of which has its own population, its own politics, its own governance. And so to have an overarching person and policy for something that can bring that together, because the London boroughs are absolutely, they are London. That's what London is. It's 32 boroughs with the City of London, each of which has its own leadership. So the mayor is able to bring that together in a way that other roles in the city are not able to do. So that's been absolutely pivotal.
I think it really has been, and we've benefited from it in so many different ways. The support of City Hall, the connection to other global cities, the advocacy that London has, because it's a mayoral initiative when it comes to the credibility for other parts of the United Kingdom. And the model of working that we have in London, I think, has informed other cities across the country and globally as well. We've hosted people from many different cities who've come to see what we're doing in London, how we're organized, and that relationship between the political, community, clinical, and academic partnerships, how it actually works in a city of 9 million people. So I think that's really been a critical part of this.
It's been very, very important. And I think that the relationships with other cities in the UK has also been really important, because we're talking about London, but we've got to remember Brighton was the first city to sign up. And if we look back, that is because already there was very good partnership working in a smaller city where everybody was already able to form relationships. And they became a fast track city within 6 months. London became a fast track city within 4 years because of the complexity. But having done that, actually, there were other cities. So we're now, we've got Manchester, we've got a huge array of other cities. And that in itself has been incredibly powerful in how we take this forward.
You know, there's so many partners who've been pivotal in our journey, and we've spoken about the mayor, but the NHS had a really unique role, and I think it's important for us just to call it out, because at a time when investment in HIV prevention was seen largely as coming through local government, and HIV and the NHS was providing high quality clinical care, for the NHS to come in to say, actually, we want to invest in a broader and deeper HIV prevention response was critical.
It was absolutely critical. And if I think back, those early discussions where we brought partners, potential partners, key stakeholders together to think about how we were going to do that piece, and the development of the roadmap, which we did very early on, which was absolutely crucial, because when we have a direction of travel, the ask for the finance is for something that is a little bit more tangible. And at that point, NHS England were able to support financially and wanted to support financially.
Yeah.
And their financial support came in at a time when we had already developed a bit of partnership working and a roadmap with some clear
Correct.
achievables on it.
And that was the roadmap to 2030 with the core
Exactly.
objective, the lanes of work that we're going to be operating in.
So developing that very early in the Fast Track Cities life was critically important. And the fact that the NHS could see there was a coherent and really achievable set of objectives meant that when money became available, it was perhaps easier for them to invest. And it was unusual for, you're absolutely right, and it's transformative.
That's right.
Because we were able at that point, because we had a partnership and we had a roadmap and we could see where the partners needed to work together, to be able to put that NHS England investment across the partnership. And so to spend some of the NHS England money in the voluntary sector was innovative and transformative. Of course, had we not had that initial injection for the NHS, we would be in a different place
I think we
now.
would. And we know that the counterfactual is true, because there are other cities, fast track cities across the United Kingdom, which haven't been able to get that NHS funding. And they found it a lot more difficult to have some of the innovation or to have some of the scaling up that we've been able to do in London. So I think that investment from the NHS has been critical, and we've continued to make the case to the NHS that this is a good value for money investment on HIV, to add to what's happening from local government and in our communities. I also remember that investment took place at a time when, because of austerity, the disinvestment in a number of prevention programs by national government, our local community organizations were going through a really tough time as well. So this investment not only helped us to come together as a group, but hopefully, I think, brought community organizations together. We were able to fund programs, create communities of practice, really thinking about improving the effectiveness of community programs. And I'm hoping that that's one of the legacies of Fast Track Cities.
I think it's a really important point. And we saw, and we still see, people competing for pots of money, when actually, if you can do it together, you are more than the sum of your parts, and the money actually goes further. And I think some of those early projects and that funding model has been transformative, both in enabling projects to happen, but for people to work together in a way that has been properly supported.
Yeah. And it also means that we've been able to fund a wider, much more diverse selection of community organizations than sometimes, we fund one or two large organizations for good reasons. But by looking at a different grant structure and modeling, we were able to fund more and smaller community organizations, which I think has helped both the diversity and the sustainability of many of those organizations too. So.
And it means that the communities that are most affected have actually had resources that are particularly directed in those areas,
That's
which
right.
has enabled, I think, more to happen on the ground.
Yeah. Well, let's talk about the Fast Track Cities model. So we've been doing this now for 8 years. I am so proud of what we've been able to accomplish, and it's been a joy to be the co-chair with you. And I think as I will bring the public health, epidemiological policy perspective to the work, you're bringing your clinical excellence, your history, and your focus on what works for patients and for people. and your clinical excellence. I think it's been a fantastic partnership, and we've been blessed to have so many people working with us. Two questions. What are you most proud of in what we've accomplished over the past 8 years? And what are your 3 standout moments over the 8-year period? And I'll share mine.
Okay, so for me, I'm most proud of the partnership, that we have sustained relationships across organizations over 8 years, where we now really have deep understanding of each other in a way that has enabled things. And it has held together and it's continued. And to have a model like that that is actually productive, and to be able to sit around one table together and to be able to disagree agreeably about things that we have different opinions about and still function. That's what I'm most proud of.
Yeah, I agree with you. I am most proud of, I'll choose another one, so the partnership definitely, but I'm really proud of the innovation that the partnership has allowed us to have. London has been, over the last 8 years, a testing ground for new ways of thinking about a very long-standing and sometimes challenging problem. But we've brought the best minds around the table from so many different sectors to think differently about the problem and to act differently and to try different things. So whether it is up-to testing in emergency departments, scaling it up in the city, whether it's a new way or new ways of thinking about tackling HIV stigma, whether it's the work that we've done to help the NHS as it continues to transform, to think about its responsibilities for good HIV commissioning, treatment, and care. We've been in spaces that normally wouldn't have been spaces occupied by others. And I've really been proud of that as well. So the innovation for me is something that I've been incredibly happy and proud of as well.
The innovation, I absolutely agree with you, has also been in the way the funding flows.
Yes.
And I think we have demonstrated a different way of doing some of the financial aspects, which again are based in partnership and trust, that money can be shared in a different way. And we're doing that in London, which has to be the way forward, but is incredibly difficult still. But we've been able to try out funding methods, ways of trying out how can money go from an NHS England budget into the community. And that has been a test ground, which I think we should be really proud of, because it's difficult and it's one of the big national barriers. People say, oh, well, we can't do it that way. Yes, we can.
And I think we have consistently faced problems and said, yes, we can. If fast track cities didn't exist, some people would say we'd have to create it. So what are the 3 things that stands out to you where you think we've made really critical contributions? You've already mentioned financial flows, but anything else stands out in your mind over the 8 years?
Well, of the programs themselves, the things that have happened, having the work around peer support in clinics is so important. We had that model at Homerton way back, but we were really sort of pushing boulders uphill because it wasn't an established thing. But to have shown the value of that has been absolutely amazing. And I think we've really moved the dial on that. And that has had immediate and direct effects on the well-being of Londoners living with and affected by HIV. It has had, you've got a partnership, you've got the money right, you've got the program, it works, and people are benefiting on the ground from doing that work. So that, for me, is absolutely, I think, top of the list. Second, I would actually, I think, pull out the GP champions. And I would also do that in a two-way way, because we knew right at the beginning how critically important GP colleagues and primary care were. And actually, we started with a slightly different project. We tried a phone line. We actually had the ability through Fast Track Cities to try something. It didn't work very well. We learned from it, and then we did it differently. And now we have the GP Champion program, which has been transformational. But we were able to try a thing and then tweak it.
Yeah. And do you have a third?
I think for me, the third is the relationships with other cities.
Mm-hmm.
And actually, one of the standout things for me has been our relationship with Amsterdam.
Yeah.
Because we looked at the data and we looked across the world and we said, actually, Amsterdam and London,
Mm-hmm.
we are both pretty close to
Yeah.
zero. We are the two cities. Let's talk to each other. How are you doing it? How are we doing it? And we had a mechanism in place because their partnership and our partnership, our problems and our challenges were similar.
Mm-hmm.
And we've been able now to form a really powerful alliance with another city. And we are learning both ways in a way that I don't think we could have done without this.
I agree. I love those three things that have stood out for you. I think for me, and I agree with each of them, for me, the special moments are because we've been working together and the trust that we've been able to build. I think we've been able to have much more frank and deep conversations around the table that enable us to work through problems. I want to acknowledge our partners such as UK Health Security Agency and the amazing data that they provide for us, which really helps us to see and understand our epidemic differently. And I think we've been working with them to get better data that enable us to commission things differently. I want to also acknowledge our NHS partners as well, who've been fantastic in thinking about commissioning clinical care, and of course the financial contributions as well that they've made for the program. And then finally, just the fact that we have so many different communities around the table helping us and keeping us checked and challenged has been amazing. But the three programs that really stand out for me are our work on quality improvement, because we wanted to use improvement methodologies through a grant program to help our community organizations to review and reflect on their programs, to strengthen the effectiveness of those programs, and to learn new skills. And that was a critical part of capacity building that nobody else would have done in the city.
Absolutely.
And from that, we had such innovation appearing that I know many of those programs have continued and evolved. And the second thing I'm proud of is our work on HIV stigma. And the fact that we've been able to fund programs like the HIV champions and ambassadors, and really ensuring that the voices and the experiences of people living with HIV are central to the story that we tell in London. And I'm so thankful for those programs and that we've been able to do that. And then finally, I love the fact that we keep thinking 2 steps ahead. We identified, as you said, that re-engagement in care is a challenge. And like you, I think peer program and embedding peer support workers in HIV clinics, critical to what we think are some of the challenges for HIV coming up. So, there's no shortage of great things that the program has accomplished over the past 8 years. And I'm hoping that, we will go from strength to strength, because those keys to success that we spoke about earlier, working together, being open, challenging each other, creating that space, and then thinking about what are we doing next? How do we keep this moving? I think that will be a key to our success.
It's absolutely crucial. I also think one of the things we're demonstrating is the power of partnerships and the work that is involved, because the trust we've built up, the joined up working, the ability to have full, frank conversations, to bring everybody in, doesn't just happen.
It doesn't happen.
And so having the support of originally Healthy London Partnership and now Transformation Partners for London, and having some infrastructure for partnership working is really important. And I think there's a sense, people say, oh, we work in partnership. How do you do that? And it needs support, it needs a foundation, it needs a home for it to thrive. And I think that's something we've learned, and we should be very proud of having that infrastructure that has enabled a lot of this to happen.
Yeah, we absolutely should. So, this is a really important time for us, because the new HIV action plan has just been published. And as you know, as the government's chief advisor on HIV, I had the privilege of working with my colleagues, both within the department, the NHS, wider system partners nationally, on publishing the plan in World AIDS Day in 2025. So we're now having our sights on 2030, ending HIV transmission in England by that time, and really driving down new diagnoses, deaths from AIDS, and tackling HIV stigma. How do you feel about the action plan, and what might it mean for fast track cities?
I'm incredibly excited by the action plan and really pleased to see what's in it. It's long awaited, and I think the process that has enabled it to be published and to have credibility, because actually it has demonstrated partnership working in the making of it, which is really important, which means that people have got ownership and can sign up to being behind it. I think the fact that there is investment is really important, because it shows that people are taking it seriously. Whether we can ensure that that is actually going into the right areas is going to be a really important part of the next few years. We are beautifully positioned, I think, in London, because we've got quite a lot of preparatory work underway. We've got structures and relationships that can take this forward. We've got to be very clear where we put our energies, and the data shows us that people living with HIV who are not able to access or be retained in long-term care are so central and crucial. So I think we've got a massive opportunity to turn some of those difficulties that we've got in our city around with what's in the plan. We've got national accountability and guidance with a structure that should enable local areas to pull in against a national approach. So London is perfectly positioned for that. And again, we've got now the new structures from the NHS 10-year plan, thinking about neighbourhoods and places as being so crucial. So partnerships in place is absolutely crucial to what we all want to do. And we have got an arrangement and a program with Fast Track Cities that is ideally positioned to do that. So I hope we will strengthen our relationships with primary care, we'll strengthen the partnership, and we will have the community, the advocacy front and centre of everything we do.
I'm so excited as well. You know, top secret, a lot of the work that helped to inform the new national plan actually came from experience here in London, because the partnership working, the innovation, the new ideas that we had in London, and the evidence that underpinned their effectiveness really enabled us to, when we're developing the national plan, to say, this works in London, these are cues for what we can do, let's make it national, let's go big with this now. So I think the new action plan will also help in some other ways as well. The new action plan talks about better accountability for delivery against our ambitions for what we want to achieve by 2030. And we've learnt in London through the fast track cities that you need to have that accountability. We need to be looking at the data. We need to be asking, are we doing the right things for the right people, and are we having an impact? And if not, we go back to the data, go back to commissioning, and change what we're doing. And that accountability we've learned through fast track cities, and I think we're going to have a chance to do more with that as well. And I think the new action plan also encourages us to be bold, to take on issues such as loss to follow-up and re-engagement in care, to take on HIV stigma, to name communities that we know are disproportionately affected. Black and minority gay and bisexual men, Black heterosexual men and women from Black African communities, white gay men. The first time a national plan has said, everybody needs to be engaged, but here are 5 groups that we want you to focus on. And in London, we know how to engage those groups. They're around the table with us, with Fast Track Cities. So we have a real opportunity here, I think, to lead the way in this.
And it's very exciting. I think we have to keep our eye on 5 years is a short time, and there's a lot to do. So we've got to be focused, and we've got to get moving and make sure that things are going forward, which we are well positioned to do, because we've got those structures, we've got the relationships to do that. I think we're going to have to really have a good think about what happens in 2040.
2040?
Yeah, no, because
Yeah,
we
why?
are aiming here
Yeah,
for the end of new transmissions by 2030.
yeah,
And what then happens?
yeah.
Because it's not over in
No,
2030.
that's right.
So we take the action plan, we run with it, and then always, as we always have done in
Always
London,
have done.
what's next?
Yes.
Because 2030 is coming quickly, and we will hopefully get to where we want to be by 2030
Yeah.
with the next challenge ahead of us. And we'll be ready.
Yeah.
And what are we going to do about that?
We will absolutely be ready. I think when I look for the journey from here to 2030, there are things that I want to do that I really want to accomplish. So, number one is I want to have consistency of our approach in doing what we know works in every part of the city. Between now and 2030, I want to remove a lot of the variation.
Yeah.
In every sexual health service that you go into, you should be offered an HIV test. For every reproductive health engagement you have, whether termination of pregnancy or for childbirth, you should know your HIV status. We want to ensure every accident emergency department is offering opt-out testing for HIV. And we even want to think about how we maximize opportunities through our primary care, through our GP partners on this. For me, the next 5 years should be about removing variation and getting all parts of London to offer things consistently and correctly so that we remove the variation. And then in the next 5 years, I'm very concerned, Jane, that we have to fight the epidemic not of 1980 or 1990, but today's epidemic. And thinking about not only people who are migrating to the UK who may be at risk for a variety of reasons, but for young gay men who are growing up in an environment where they're not seeing HIV deaths. They're not seeing HIV messages around them to say, actually, safer sex is important. Here's how you protect yourself. So there's a real danger that as we focus on ending the epidemic, we will leave people behind.
Absolutely.
Because we're assuming that everybody knows about HIV. And that's a fatal assumption. We've learned that in the pandemic.
And we have had change throughout this epidemic. It's one of the things we are good at. And we have to remember that everything is changing and we have to change as it changes and be nimble and flexible. And we've got that potential to do that.
Yeah, we absolutely do.
Well, it's a huge pleasure to be talking like this. And actually, I just want to say thank you, because we could not have done this, I don't think, without some of the leadership and thought and expertise that you've brought to this program. So whenever it was, we sat there in Melbourne saying, get Kevin. Thank you.
Well, back at you, my friend. It's been such a privilege and a joy to work with you and all of the members of our Fast Track Cities team, both in London and across the country, because we keep learning from everybody. And we've created an ecosystem, sounds grand, but we've created a network of partners who are committed to making this work. And it's such a privilege to be with you on this and to be with everyone as well. So thank you.
Thank you to Professor Kevin Fenton and Professor Jane Anderson. The views shared in this episode are those of the contributors. We all bring our own perspectives, shaped by personal experiences. These conversations help to create a space for honest discussion, keep the conversation going, and to normalise the topic. Thank you for listening, and we hope you tune in to the next episode.